Good afternoon. My name is Dr. Brian Levine, and I am the practice director of CCRM New York, a comprehensive fertility center here in Midtown Manhattan. Today, we're going to actually take the time to discuss one of the most common conditions that we see in clinical practice, polycystic ovarian syndrome. PCOS, or polycystic ovarian syndrome, is a metabolic condition that can be described as either an abnormality originating in the ovary or an abnormality relating to how we look at things such as insulin or the hormones that are produced by the brain. When we look at the patient who has ovarian syndrome, what we have to do is to first ask the simple question is, how are we making this diagnosis? There are certain things we look for. For example, does she have regular cycles? That means that she get a period every month. When she gets her cycles, are they regular in the sense of every 28 days, every 21 days, or more commonly, every 35 to 40 days? That's one of the hallmarks of PCOS, irregular cycles. The next thing we look for is, does she have any signs or symptoms of what we call hyperandrogenism? Or quite simply, excess testosterone being in the body. That's simply looking at someone and saying, do you have bad acne? Do you have excess body hair? Or do you notice that you're having some changes, such as even male pattern baldness, that might be suggestive of having an abnormality of the androgen level within your body? The third part of the diagnosis is what everyone thinks of, which is the ultrasonographic findings, which means basically when you go to your doctor and you do an ultrasound, which is a transvaginal ultrasound, and we look at the ovaries, is do you see a lot of follicles or eggs? That's where the disease really gets its name, polycystic, or lots of little follicles all around the ovaries. However, it's important to understand that there are a lot of conditions that can look like PCOS. And the treatment of PCOS is important because you need to treat the disease the right way. And you don't want to be treating a mimicking condition. So, for example, someone might come in saying they have irregular cycles and they're very much bothering them. We quite often see that these patients are put on birth control pills by their obstetrician and gynecologists. However, a birth control pill, although it might be the correct treatment, might just be masking what's actually going on with the patient. Does she really have PCOS? Does she really have an ovary that has a lot of eggs that are there? Or are we finding that that patient maybe is a marathoner or a gymnast or a ballerina who has such a low body fat composition that she doesn't get regular cycles? Again, a regular cycle is getting your period like clockwork. 28 days, 29 days, 30 days, just consistently every month. So while a birth control pill might be a quick fix to make sure that patient gets a regular, predictable cycle, in reality, it might also tell us not much about what's going on, although it could be the treatment. What we find is that women come to us with PCOS for a number of reasons. One is the unpredictable bleeding. I don't know when I'm getting my period. I feel like I'm always going to get it, and then I don't. The second reason that we find that people come to us with PCOS is because they're concerned about health maintenance. They know that their friends get regular periods, and they feel that something is off because they're not getting the same regular period. And in that scenario, it's important to understand that as reproductive endocrinologists, we treat patients who are not just trying to get pregnant or stay pregnant. We treat people through their entire reproductive lives. So it's important to recognize that people with PCOS could be set up for other conditions. For example, with polycystic ovarian syndrome, we see sometimes mild insulin resistance. In plain English, the pre-diabetic patient, where maybe they have to be careful how much carbohydrates or sugar they're having because they have the ability to gain weight quickly. Or, for example, we might find that the patient with PCOS is having the acne and the excess body hair problems. Or we might find that the patient with PCOS is actually gaining weight so much that they're now not getting periods, but they're getting spotting quite often. These are the patients that need to be checked carefully, because in a woman who has irregular cycles, you want to make sure that there's not something else going on in her body. And so what a lot of people don't recognize is that PCOS, which people usually try to treat for acne or fertility, can also be a precancerous condition, where if someone's baseline estrogen is very high, for example, due to obesity, and if they're overweight, they might have something like an endometrial polyp or a growth within the uterus growing. Ultimately, what you need to do is to make sure that the patient's evaluated. And so PCOS is not something that should be just brushed off and treated with a birth control pill. The patient should be properly worked up and diagnosed. However, as a fertility doctor, the most common thing that I see is someone comes to me, and someone may have made the diagnosis of PCOS ahead of time, or we may have diagnosed it ourselves, and they want to get pregnant. So in our practice, we follow the American Society of Reproductive Medicine guidelines, and we use an evidence-based approach that starts with first seeing if the patient has a regular cycle, doing a series of blood work and ultrasounds to figure out exactly what we're dealing with, and then making a treatment plan where the risk-benefit ratio is appropriate such that the patient's taking as few risks as possible. Some of the treatments that we can give patients are oral medications. So one of the oldest, safest fertility drugs is a medication called Clomid or clomiphene citrate. And that's a pill that helps trick the brain into pumping out more hormone to make more follicles to help the patient ovulate and get pregnant. As we said before, PCOS, the hallmark is irregular cycles. So Clomid doesn't make you ovulate as many people think. It helps you make a better egg or follicle that ultimately helps you ovulate. So we can use Clomid, but we always counsel patients that the risk of using Clomid is getting twins. We can also use another drug, which is newer, called letrozole. Letrozole was originally a breast cancer drug. Originally was used to help people keep their estrogen low. But what we know is that patients a drug like letrozole to keep your estrogen low, you can trick the brain to, again, just like with Clomid, pump out a little more hormone to make follicles. And we know that the twin rate is lower and the rate of multiple births is lower with letrozole than Clomid. When approaching the infertile couple or patient who has PCOS, I think it's very important to counsel the patient about patience. Although they may believe that they've been trying for a year to get pregnant, it's important for that patient to understand that without regular cycles and regular ovulation, they may not have been trying appropriately at all. So these regimens, such as Clomid or letrozole, should be given, and the patient should understand that it's a series of cycles or months of trying to optimize that cycle that should be most carefully done and not rushing to the next step. If after a series of months and trials that the Clomid and the letrozole don't work, and you can either do processing of the sperm of the partner called an intrauterine insemination or an IUI, where you put sperm back inside the uterus, if the combination of Clomid or letrozole with or with, there is a second approach that can be used. And that second approach is to give patients very low dose of fertility hormones to help recreate the normal environment in the body, to help select a proper egg to be made, and then we help that patient ovulate by triggering ovulation with medication. If it sounds complicated, it's because it is. And in my opinion, it's also one of the most dangerous approaches that we can have, because patients with polycystic ovarian syndrome can respond very well to even the most mildest doses of follicle-stimulating hormone or fertility drugs. Because of that, we're very careful to pick the right patient who can undergo this treatment. And the truth is, the patient has to be counseled very, very carefully, that there's a high likelihood that she will over-respond and the entire cycle will have to be canceled because of the risk of having twins, triplets, or quadruplets. If the patient is not willing to undergo a cycle, that she could be canceled, or we find that she's not a viable candidate for doing the daily fertility shots with or without an insemination, the patient can progress on to in vitro fertilization. Of all the patients in our practice, I think we worry the most about the patients with polycystic ovarian syndrome when they move on to in vitro fertilization. To do in vitro fertilization, or IVF, a patient has to take daily injections of fertility hormones for approximately 10 to 12 days. At the end of that process, there's a procedure to remove the oocytes, or eggs, which is done while the patient is asleep, and is done gently with an ultrasound and a needle, as the needle is guided into the follicle and the egg is removed. The reason we worry so greatly about patients with polycystic ovarian syndrome undergoing in vitro fertilization is because these patients can respond very quickly. And if they respond very quickly, and in fact quite robustly, to the medication, they can end up in a scenario that puts them at risk for something called ovarian hyperstimulation syndrome, another acronym, OHSS. And in my career, some of the sickest patients I've seen with OHSS have been these PCOS patients. The reason is the PCOS patient has lots of follicles, and then we give them hormones and they get a very robust response. And once the train has left the station, sometimes it's hard to pull it back. We have great strategies that have been developed to limit the risk of ovarian hyperstimulation syndrome. For example, if we think of patients at risk, we can freeze all of the embryos upon the IVF cycle and transfer them back at a later date. Or we can use a different type of medication to help trigger the oocytes to be mature to limit the risk of ovarian hyperstimulation syndrome. But treating OHSS is part and parcel of what we do in our clinic. And I have to admit, it is probably one of the most rewarding diseases to treat, because quite frequently, these are the young, healthy patients that we can help them achieve their goal of having one healthy baby at a time. Before I start to answer your questions, as I see the questions are all coming through here, I just want to make mention that our clinic, which is part of the network, which is the Colorado Center for Reproductive Medicine, or CCRM, is supporting the National Polycystic Ovarian Syndrome Association. The National PCOS Association, just so you know, is the leading 501c3 or not-for-profit, and it globally advocates for patients who have PCOS. So it's important to know that there are support groups and there are people out there who are fighting and helping for our patients to get recognized and treated, and to make sure that they go through this process as easily as possible. And we support and salute the National Polycystic Ovarian Syndrome Association. So with that, I'm going to start to answer some of the questions that are coming through. And I'll start with this first one. Someone has asked, how do I know if I have PCOS? Well, as we said before, the initial breakdown of the three things, irregular cycles, evidence of hyperandrogenism or excess body hair or acne, things like that, and polycystic looking ovaries on ultrasound are the hallmark of the diagnosis. So if you go to your regular OBGYN, you can have this discussion, and it can be a simple evaluation. Someone just asked, with PCOS, should one start IVF earlier than someone without PCOS? So that's a great question. And this is why I think it's really important that doctors partner with their patients. When a patient is pregnant, we both succeed. And when a patient is not pregnant, we both failed. But I also often tell my patients, I take the responsibility when someone's not pregnant. So with PCOS, as I said before, it's an incredibly rewarding condition to treat because quite often minimal intervention, oral fertility drugs, Clomid and letrozole and things like that, can be the ones to help the patient achieve their goal. And so in fact, I would say don't rush to IVF unless there has been no response to the oral medications. And if you were to offer me the opportunity to either give daily fertility shots or do IVF, I'd rather do the safest approach, which would be using IVF. There's a question about, can I talk more about CCRM? So CCRM is an acronym. It stands for the Colorado Center for Reproductive Medicine. This is one of the nation's leading fertility clinics. It was founded in Denver, Colorado, hence the name, by Dr. William Schoolcraft. We now have 10 locations across the country. We're on all the corners of the United States and also in Canada and Toronto. And we are a comprehensive network of fertility clinics. Our goal is to help patients on their fertility journey, maybe people who have trouble getting pregnant, people who have trouble staying pregnant, or those who want to freeze their eggs or sperm, either for personal reasons or even with the new diagnosis of cancer, for example. If you go to our website, ccrmivf.com, you can learn more about the services that we offer at CCRM, and hopefully there's a location near you. So here's a great question, which is, how does nutrition play a role with fertility at a very high level? In short, if you have PCOS, you might be mildly diabetic and not even know it, which means you might respond to carbohydrates and to other nutrients differently than the average patient. As such, we actually work very closely with dietitians and nutritionists to help our patients create a healthy environment in their body that is ideal for getting pregnant. In terms of nutrition, also as it relates to other fertility conditions, the rule of thumb is to try to avoid white things. So we tell people that if you avoid white rice, white wheat, white sugar, white milk, these also work well for PCOS patients and also for those inflammatory patients, the ones who might have some sort of irritable bowel syndrome or something that's going on that's causing some sort of inflammatory process in their body. And hopefully we find by helping people have a low inflammatory diet that they usually can get a better outcome and sometimes even have cycle regularity on their own. Any other questions you might have? To just expand upon the IVF that we discussed before, for patients with PCOS, it's no different than if you had any other condition like poor egg quality or poor sperm quality. The only difference is that when it comes to doing in vitro fertilization with patients with PCOS, we probably have you come to the office more often to watch them. The reason is we want to be careful to not allow you to have hyperstimulation syndrome. So opposed to the regular infertile patient, those with PCOS tend to have much closer monitoring. There's a question about exercise and PCOS. This is like the diet question before. Being healthy will help control PCOS. And given that one of the theories of PCOS is that it does deal with insulin resistance, we often counsel patients that if you lead a healthy life, you can hopefully help reduce the symptomology of the PCOS. And so by reducing your body fat content, you can probably have a better outcome. So diet and exercise are key. So while we're waiting for some other questions, I'll discuss the history of PCOS. So PCOS is a condition that we've known about for quite some time, and it's undergone some changes in the definitions. And of course, we use the most modern definitions now, which is that triad. What we have found in the past was that some patients were actually undergoing ovarian surgery, so laparoscopic, or the 3 little holes in the belly to go inside, and they were actually having their ovaries burned or partially destroyed. And the idea was that if you could cut down the amount of tissue in the ovary, maybe you could make the ovary have fewer eggs, and then you would get normal cycles. And in fact, in some patients, they found this worked. It was called ovarian drilling. However, why should a patient have to go through surgery if they don't need it? So no longer do patients undergo ovarian drilling as an approach of how we can treat PCOS. There's a question here about CCRM success rates with PCOS. I think we're on par with almost every other condition. So our success rates are incredibly high, and we meet or exceed the national standards for treating with in vitro fertilization and non-in vitro fertilization techniques. In general, our PCOS patients are our greatest success stories because they tend to be very young women who are coming through. It's very easy to know you have a problem when you come off the pill and you have not had a period for 6 months or a year. The tougher patients are the ones that everything has been fine for so long and they have no idea that they've been dealing with a fertility issue for longer than they anticipated. So I would say more likely than not, our PCOS patients are getting pregnant quite frequently with a singleton, which means a single pregnancy. There's a question about the birth control pill. As far as we know, the birth control pill does not have any adverse effects on future fertility. In fact, being on the birth control pill for 5 years or more can reduce your risk of ovarian cancer by 50%. It has been thought that reducing the risk of ovarian cancer is due to limiting the number of ovulations. We also think that in the patients with PCOS, it probably helps with the protecting of the lining of the uterus or the endometrium, because it gets you to bleed every month. The reason that some patients with PCOS are at risk for endometrial cancer later in life, or cancer of the lining of the uterus, is because they don't get a regular bleed every month. So in fact, the pill can help prevent an untoward outcome or an awful side effect or sequelae of PCOS. In the last 2 minutes, are there any other questions that you may have? Don't be shy. These have all been wonderful questions. I've really enjoyed them. So I'll wrap up in the last minute to just say that I've really enjoyed having this opportunity to speak with all of you about polycystic ovarian syndrome. Feel free to reach out to me directly if you'd like. I'm happy to answer your questions over email. My email address is B as in boy, Levine, Levine, at CCRMNY.com. Again, that's B as in Brian, Levine, Levine, at CCRMNY.com. I'm happy to answer your questions, and I really appreciate you taking the time to learn a little bit more about one of the most common diseases that we see at CCRM and that we treat successfully. Thank you again for your time and attention, and hope you enjoy the rest of your day. Thank you.